welcome to all our participants joining us here today. I'm Dr. Muskan Alawat and I welcome you all for this insightful virtual panel discussion on value improvement, delivering better outcomes, better experiences, and better use of resources. We are truly delighted to have with us experts who bring together, share some perspective, experience, and some actionable insights on how value improvement moves beyond traditional cost saving initiatives to focus on achieving better patient outcomes, enhancing patient and staff experience, as well as making the best use of available resources. Before we begin, I would like to briefly introduce Nivara Healthcare Improvement. Nivara is a quality improvement consultancy dedicated to bring and make healthcare safer, smarter, and more patient centered. They work closely with healthcare providers to build resilient systems, reduce preventable harm, and elevate standards of care across the ecosystem. I would also like to take a moment to introduce Voice of Healthcare. Voice of Healthcare is a dynamic platform dedicated to making healthcare a priority for all. It brings together diverse stakeholders to foster collaborations, dialogue, and innovation across the healthcare ecosystem. So, as an impact driven platform, we amplify ideas, voices, and policy conversations shaping the future of care. Now, it's my pleasure to introduce our speaker for today's session, Dr. Poonam Gupta. Welcome, Dr. Poonam, to the session.
Thank you.
Dr. Poonam is a physician and an international leader in patient safety and quality improvement with over 17 years of experience across Middle East, India, and the UK. She has experience in designing, leading large-scale improvement collaboratives. Dr. Gupta is currently serving as Senior Improvement Advisor and Value Improvement Lead at Oxleas NHS Foundation Trust. She is also the Assistant Deputy Editor of the International Journal for Quality in Healthcare, a published author and a book author as well. Her work focuses on safer healthcare systems, leadership, and value based care, as well as sustainable improvement. I welcome Dr. Poonam to this session and would look forward to her insights at today's discussion. Now it's my privilege to introduce our moderator for today's session, Dr. Mahtab Singh. Welcome, Dr. Mahtab, to the platform.
Thank you, Dr. Moksha.
Dr. Mahtab is a highly respected name in public health and healthcare quality improvement. He is the founder, member of Nivara Healthcare Improvement LLP, where he leads operation and management, and also a key force behind the nationwide quality of care India of care network. Having served as his former vice president with over 30 years of experience in public health, he has been deeply involved in designing and implementing large scale healthcare programs, working closely with government stakeholders at both state and national levels. He has also contributed extensively to the field through multiple publications in peer reviewed journals. So, with that, I would like to hand over the session to our moderator, Dr. Mehtab, to take the discussion forward. Over to you, sir.
Thank you so much, Muskan, and I again welcome all our participants and especially Dr. Poonam Gupta, who has taken out some time from her busy schedule and NHS. I know see how busy she is, and I also welcome her to deliver this talk on a very important topic. Poonam, we all know everybody whosoever visits our hospitals needs the better outcome, better experience, and optimal use of resources. I think in our hospitals we think it is the duty of the hospital staff only to give all these things, but value added by everyone, even patient, relatives, doctors, nurses, or even the financial part involved in any service is very important. So I think we have a lot of learnings today here from you to listen, and finally I would take more time of you. So hand it over to you, Dr. Poonam, please.
Yeah, thank you so much, Dr. Mehtab. So first of all, thank you so much for having me on this platform and giving me this opportunity to talk on this platform about the value improvement, which is really I'm passionate about the value based care, and it's like I'm working on value based care, value improvement, like it's more than a decade now. So I would be really delighted to talk about it. And once again, it's really it's a pleasure to be here today. So can I have my slides on, please? First of all, very good morning. So it's a morning here. So very good morning from UK. So today I'm going to talk about value improvement, and which Dr. Muskan and Dr. Mehtab has kindly given a nice brief context about it. So we will be talking today about delivering the better outcomes for our patients, but at the same time, better experiences for our patients as well as our staff, and the most important part, how we are going to use our resources in much better way or most efficient way. So that's what we are going to talk about in coming hour, or coming a few half an hour or 45 minutes or so, and then at the end of the session we'll be more than happy to take some questions from you. Next slide, please. Okay, I can move myself. So what is the objective of today's session, what we are going to talk about today? So first of all, we'll just do some deep dive, understand what is the concept of value management or value improvement. It's one of the same thing: value based care, value management, value improvement. So we use these terms interchangeably. So first we'll just talk a brief about what is the operational definition of value. Then, second, we'll talk about what are the methods we can apply in terms of quality improvement, which will help us in achieving the value, reducing the cost or maintaining the cost. So many times it happens that in our strategic objectives, we are being told that, oh, we need to deliver the value based care. But no one talks about the delivery engine, how we are going to deliver that value based care. So today we are going to talk about that, what could be the method which will help us delivering that value. And then we'll talk about some financial tools, financial and then productivity tools, which can help us in achieving that value. So that's the objective for today's session we are going to talk about. Now, this is not new in the industry. What I'm going to talk about today, I'm sure that many of you can correlate. If you are working in quality improvement, then definitely you must be aware of some of the terminologies, what I'm going to use it now. So that's not new. We have heard about lean methodology since years, like we are Six Sigma, lean, and all. So basically, this method, it is use of practical lean accounting principles. So in this one, what we are trying to do, we are already using model for improvement for delivering quality improvement, or we are using MFI as a framework for any quality improvement project or anything related to the quality when we are doing in our settings or in our hospitals. But here, if you'll see this book, this is written by Brian Maskell, The Practical Lean Accounting, and he has extensive experience in manufacturing industry for lean accounting principles. So ICHI, Institute for Healthcare Improvement, which is a non-for-profit organization, they are based in Boston, and they are pioneers in leading the quality and safety, quality improvement. So they just they just wanted to see whether can we use this lean principles in healthcare settings, and if we are going to use it, will we be getting the desirable results? Like, can we get the value, or can we improve the value while using those principles in addition to the MFI or quality improvement principles? So what we are trying to do here, we are trying to merge these two concepts. We are using quality improvement framework, but at the same time, we are using some of the lean principles as well. And that's how we are trying to create a framework where in healthcare, we can generate value, or we can achieve the value-based care. But why it is important? Why we are talking about value-based care today? So if you'll see this data, but this is not from India. This is basically from US, and it's evidence-based. You can search literature, and there are many literature available on this one. So there are really a lot of waste involved in our processes. So almost 25% of healthcare spending, it is considered wasteful. And if you'll see how much it's being translated into terms of money, millions, right? So when I say value improvement, or when I'll be talking about value based care, so no one should think about it is a cost cutting exercise, or it is something where we'll be okay, we'll fire some people, we'll reduce the headcount, and then we will achieve the value. No. So value improvement or value management, it's not about cost cutting. It's the waste cutting exercise. So we are targeting about, our target is this 25% waste, which is, even if you'll just try to process or just try to think one process which is happening in your hospitals right now, you will think that, or you will come out with, oh, there are lots of things we can just skip, we don't need that. So value improvement basically focus on waste. We remove the waste or we minimize the waste from the processes, and eventually that leads to the saving money. So money is always a byproduct of streamlining your processes or making it more lean or more, efficient. And eventually at the end of the day, you will save money. That's for sure. So that is the main thing. When there is a lot of waste involved, we are trying to reduce or cut that waste. But what is the problem we are trying to solve? And I'm 100% sure that everyone will agree with me here. Healthcare system, we are swimming in data. We have a lot of data sets available. If you'll just go and have a look in your hospital dashboards or data system, you'll be having multiple nice dashboards, red, green, yellow, amber colored, or we are up to the mark, we are green, we are not doing good, we are red, the traffic signals and all. But from my experience, almost 16, 17 years now, whenever any team, frontline staff, they are coming to me for any idea or anything, oh, we are having a lot of readmissions, or we are having delays in care delivery and all. So the first thing they ask us is from where we can get the data. So although we are having at one side really nice colorful dashboards available, but on the other side, whenever frontline staff, they are trying to make improvement, they don't have meaningful data. So what we are trying to do in value improvement or value management, that we are trying to give right data to right people at right time. And in that way, they will be able to make the improvement as close as possible to the real time. And why it is important to give real time data, or maybe, just as close as possible to the what happened, like maybe last week or maybe 1 week before. If you'll ask me what I had in my dinner 2 days before, I won't remember that, really, to be honest. We forget, isn't it? So same happens with any incidences or anything happens in the wards. If you will ask me, okay, your data, it doesn't look like it was from February month or March month, it will really take a long time for me to understand what happened during March or what happened during April month, why this data doesn't look good. I'm not sure what happened, I just forgot. But if you will ask me, oh, your last week data, it shows like, you have a lot of consumables you used in your ward, I'll be happy, or I'll be more than vigilant to recall that one. Oh yeah, because last week we had a lot of long-term care patients, or there were a lot of sick patients, and that's why the consumable cost went up. So we really want to give that kind of empowerment to frontline staff where they can recall. And so when it will be possible, when they have the real-time data and meaningful data. And this is the definition, operational definition, what we are using for value. It's quality divided by cost. It is Potter's equation. And in quality, when I say quality, it's not only the outcome. So 100% patients at the center of everything what we do. But at the same time, we are talking about patient and staff experiences as well. So their outcomes plus their experience while they are in our care. And at the same time, staff experience as well, care for the caregivers. And I think COVID taught us this one, why it is important to provide care to the caregivers as well, because when they feel good at work, they will be better able to serve our patients. But at the same time, we need to keep an eye on our cost, which is direct cost, indirect cost. And when I talk about cost, make sure that I'm very much aware that it's just variable cost. I'm not talking about fixed cost. Fixed cost, it means building cost and bed cost. That's not my gift. That we can't do anything about that. My or our gift is variable cost, consumables cost, dressing cost, or avoidable cost avoidance. For example, healthcare associated infection cost. That's the avoidable stuff. That's my gift. So I can't do anything about the fixed cost. So that's the definition we are going to use. So why this method? Because it addresses several challenges: financial pressures, year-on-year healthcare inflation. It's not the single system. It's around the world. Every healthcare system around the world, we are undergoing a tremendous financial pressures, and we are having this pressure to deliver the value-based care. We are seeing the aging population. They have higher care needs, and there are many people with multiple long-term conditions, but much of our money, it says, in episodic acute care, it is being redirected. So we really need to think a way where we can deliver the value-based care and can have reallocated that money where it is most required. So what actually this method is and from where it is originated. So just a brief about that. So as I mentioned, that high value healthcare, best outcome, but at the same time, lowest possible cost. So as I was explaining that, very first it was developed by IHI, Institute for Healthcare Improvement, and it was somewhere in 2016. And then this method, it was being piloted in Regmore Hospital, NHS Scotland. It was a respiratory ward, and it was proven to be effective. Really, it went very well there. And then I was working in Qatar that time. It was a tertiary cardiac care setting. And then we were working with IHI very closely. And then we thought, okay, let's try this. And even in Qatar, it was proven to be very effective, positive impact, reducing cost, improving quality, efficiency, safety, everything. And after that, multiple healthcare systems around the world, they use this approach and are using this. At Qatar, we did last year 22 teams from Saudi Arabia, then NHS Scotland, they are doing it in Ireland, Northwell Hospital in USA, few facilities in Brazil. I'm doing it in Oxleas NHS Foundation Trust, and we are into spread and scale stage. We started with a frailty team, and recently we are looking for this work in University Hospital Birmingham. So those are the places, like slowly, gradually, the method is gaining that traction. But one most important thing, what we are trying to incorporate here, a co-production lens. So involving patients, carers, staffs in designing or change ideas. So right from the beginning, not when already things have happened. And one more thing which is important, applying a return of investment lens, so that we can demonstrate the financial savings, we can demonstrate the outcome returns, operational savings, and everything. So there are a couple of principles we are incorporating into the value management lens. So what is the equation which was given? So very simple, but yeah, maybe hard to achieve, but on paper it looks really simple. If you have a visual management system in your unit or in your facility, if you have some sort of communication method, could be daily or weekly, if you have improvement capability in place, like what Dr. Mahtab and Dr. Kedar, they are trying to build through different programs. If you have a will to solve the problem, I think this is really, again, very important. And the leadership support. If somehow we can get all these pieces together in our facility or in our organization, then definitely it is possible for any organization to achieve the culture of continuous improvement. It's not something which is impossible. And I can say this from my experience. I have seen that. I have seen the culture of continuous improvement in a couple of settings where I have worked. And when it happens, it is tangible. You can sense it. So, what is the method? Now I have created a lot of excitement when I'm talking a lot about, oh, this method is really good and all. But what actually that method is? So, if you are from QI or quality improvement background, I'm sure that you must know that what is model for improvement. So, if you remember model for improvement, still this work is underpinned by model for improvement. This is the solid foundation of any improvement work, but value improvement is one step ahead of model for improvement. So model for improvement plus three more things what we are trying to incorporate. So the value management is having a box score, having a visual management board, and then weekly huddles. So very simple thing, which if we are going to incorporate in our day-to-day life or in our quality improvement or quality framework, whatever we are doing in our settings, then definitely we can try to create a value-based care in our setting. I'll just go brief about what actually these things are. For example, let's start with the first thing, box score. Again, not something which is rocket science. Very simple, just an Excel. But the difference is here we are not only talking about the performance measure, which is historically or conventionally, we are giving a lot of importance to the performance metrics. But here, apart from performance metrics, we are talking about finances and productivity. I have seen many frontline staff when they say, "Oh, finance is it's not our concern. Finance is finance department. Go and talk to finance department. We are not aware of it and we don't want to know about it." No, we want you to know about finances, and that's the kind of empowerment we want frontline teams to have, so that they know what is this drug cost, what is this consumable cost, and how we can maximize or how we can create more efficient workflow. So how it look like? So a simple Excel, this is how the box score looks like. Your performance metrics, your productivity, your capacity metrics, and then your finances. The second important thing is a visual management board. And again, not a rocket science. It's just what we are trying or what we are asking any team to do. Put your data or put your charts and your QI efforts on a board, visible board. And I would definitely recommend it should be in the most visible place in your unit. Even patients should see this. Of course, there shouldn't be any confidential information, but even patients should see this. Oh, see, we are trying to work every day. We are trying to become better every day what we were yesterday. So those are this will reflect your charts, your data. So everything should be there on your visual management board. But what happens with the visual management board? You can ask me. And then it allows everyone to get on the same page very quickly, irrespective of, I was on night shift, I didn't know that there was a fall happened. Oh, I was not on shift, I was on leave this weekend, or I took some days off. But if you have things on your visual management board, everyone in the unit, they will be on the same page very quickly. Graphical display of performance over time, so that will allow rapid recognition of defects and opportunity for improvement, and at the same time recognition of improvement, so you will get some moments to celebrate. Oh, there are 100 days free of pressure ulcers, wow, we should celebrate, we should bring a cake, isn't it? And it helps us to connect the whole system from senior management to frontline teams at the same time. Just go in your unit, stand in front of your board 2 3 minutes or 5 minutes maximum, and you will understand how this unit operates or how the patient care looks in this unit. And the last one, which is my favorite, it's huddles. So huddles is really my favorite. And why it's just 15 minutes, 10 to 15 minutes maximum in front of the board, where everyone, whosoever is available in that shift, should come in front of the board and talk about the data. We recommend that on the same day, same time every week. For example, Monday, 10 to 10:15. And there are some huddle hygiene rules we have prepared, like it should be strictly standing huddles. Once you will start sitting and doing the huddles, you will be very comfortable, and then it won't be any more huddle. It will be a meeting, 45 minutes, 50 minutes, 1 hour. We don't want that. Strictly standing huddles, 10 minutes, just talking about the data. That's it. And that's how we are trying to communicate our findings. So how we are going to test this model and how it is being spread? So there are multiple methods what we used around different countries. So generally this model we started with single pilot unit, just prepare the that unit, whether it will be working, it won't be working, testing, failing, and then coming up some proof of concept from that unit. Then again trying to bring on board 4 or 6 additional teams, different scope of services, and then eventually scaling it up. So this is the very first model which was tried in Scotland, Qatar. We are trying this in Oxleas. So this is one model, and again there are multiple things the speed depends on. Then there is second model which we tried in Saudi Arabia last year, and we are trying to do that same in University Hospital Birmingham if we don't have time. But because this method, it takes time. If you don't have time, then you use the BTS approach, breakthrough series approach, where you bring all the teams together, 12 teams, 15 teams, and then all of them, they start the work together. Because we already have proof of concept from some different setting. We did that with 22 teams together from Saudi Arabia. So there are different models. This can be scaled up. You can try in your hospital, start with one unit and then slowly, gradually up, or you can bring all of eligible or maybe interested units together and try this approach. One thing which I would really go very brief, how we are using this principle or this method to connect the system thinking or strategic aims linkage. So although it looks really scary, but it's not scary, to be honest. On the left hand side, if you see, it is a system strategy. So many organization, hospitals, they come up with some big strategies, organization goals and all, but frontline staff, they are not aware how I'm going to contribute to that strategy, right? So what we do with the teams, we allow them to link their work or their metrics with the system strategy. So every team, they are aware that if they are going to work on particular initiatives, whether it is length of stay, whether it is false rate, pressure ulcer, CLEPSI, COUTI, how they are turning the dial so that the organization is eventually able to achieve their system strategy. I have done multiple workshops where I ask the first question, where there are, all frontline teams in the room, and are you aware what is your system strategy? Are you aware what is the organization objectives and goals? And to my surprise, only middle managers and the senior leaders, they are aware of the answers. But the frontline staff, who is, very close to the patients and delivering the care, they are not aware about it. And you are not aware about it, how you will contribute to that. So this is a very good exercise and fruitful exercise what we try to do with the teams, and it gives them a sense of achievement. Oh, we contributed to the strategy by doing this work, isn't it? So that's how it looks like. But at the end, some results, let's talk. So we did all this stuff, and then what is the result? So I'm explaining brief about some results from different healthcare systems around the world. Now this is from I think this is from Scotland, where there is a considerable amount of reduction in average cost per patient and the bank nursing. So bank nursing, in a very simple word, if I'll explain, it is sort of overtime nursing. So if you'll see, it is considerable reduced, both of these things. So it means we are improving the productivity, and we are trying to reduce per patient per day cost in our care in inpatient setting. This is the consumable cost, and again it is from one of the intensive care unit, and you can imagine the intensive care unit consumables, how costly it is. So there was almost 25 to 40% reduction in the consumable cost. Then number of x-rays reduced, again in one of the unit. And when I say number of x-rays reduced, it could be just a number for someone, or it could be just the cost for someone. Maybe this is the cost. If you will reduce the number, the cost will reduce automatically. There is no surprise in that. But for me, the most important part of this is when I'm reducing the unnecessary x-rays, it is unnecessary exposure to the patients for radiation and for our staff. So we are not only reducing the unnecessary x-rays, unnecessary exposure to our staff, to our patients. So it's a win-win situation for everyone. And then, and this is performance metrics, which generally, conventionally, we are using a lot in our QI. This is early discharges for the patients so that they leave the unit as early as possible. We prepare the bed and then we pull the patients from ER. Then this is the nursing care capacity. It is face-to-face care delivery. You'll see it increased from 55% to 75%, and why I'm saying it is in morning shift, because 3 shifts, morning, evening, and night, they are not similar. Their dynamics are entirely different, isn't it? Morning shifts are very dynamic. You have doctors around, you have patients, you have their families, the discharges are going on, you need to give discharge education. There are lots of things goes on in morning shift. And we want nurses to talk to the patients, to their carers or relatives more, and so that the discharge instructions are proper and all. But at the same time, in night shift, it is quiet. So that's how it is being distributed. Average length of stay, again in one of the ICUs, you can imagine any ICU bed for any country, how precious it is. And then a lot of other performance metrics, CLEPSI, CAUTI, VTE, phlebitis. So there are multiple results from different healthcare systems around the world. So this is evidence-based. If you'll go and search on internet, you'll find many peer-reviewed QI publications for this work in BMJ Quality and Safety, BMJ Open Quality, Joint Commission Journal, in Harvard Business Review. You can find about this work. This was the award what we received in Qatar this was the most prestigious award for their quality and safety. And it was from their managing director, the health minister award for this work specifically. So over a period of time, over a decade, we worked for this methodology through multiple countries, several healthcare systems, multiple teams, whether it is inpatients, outpatient, emergency departments, in community nursing. And we tried to incorporate all the learnings, and now it's converted into a book. It was released in January 2026, and it was published by Taylor and Francis Group. And it is getting a very good engagement. It received some institutional buyings as well. So you can definitely check it. It's already available on Amazon. I'm not sure if it is available in India, but this book has a lot of learnings from everyone. And this was the end of my presentation, and thank you for listening. And I'm happy for taking any questions and comments now. Thank you.
Thank you so much, Dr. Poonam, for sharing so wonderful, experiences and your work all over. I'll say, the North, Middle East, Europe, and even we are trying to bring same sort of things to India also. I have learned a lot of things from this, because value is something which we need to consider everywhere. But sometimes value for us is money only, and that's what misguides us. Value is everywhere. Even if patient's relative gives us 20 minutes for care, maybe doing a simple procedure like kangaroo mother care. That makes a lot of difference.
True.
So before I hand over to Muskan for any questions from audiences, I personally have a couple of queries to
Please.
clarify. The first one, I think everywhere in India or this part of the world, whenever we go to a hospital, quality means getting a certificate. Maybe some government certification, ACI, Joint Commission, or maybe NABH, and we have now millions of facilities certified. But what do you think? Age certification alone is enough? So this is my first question. So your views, and then I'll come up with the second question.
Yeah, that's really a fantastic question, Dr. Mahtab. I must say that. So yeah, and for sure, accreditation is important. We can't replace that. That is, there is no second thought about it. But for me to describe this, like accreditation is important. So I will describe this accreditation as a soil or maybe as a floor where we build the foundation, but at the same time to create that continuous improvement, to try to deliver the better care and all, we need a culture of continuous improvement. Accreditation is all about having things in place. If you have all the policies in place, if you have all the documentation in place, and to be honest, that's the bare minimum we can do for our patients, isn't it? You will see that even if any healthcare organization, even if they have accreditation in place, they have all the policies in place, they have all the infection practitioner IPC policies, everything is in place, right? But still the patients are getting harmed. Still you will see that their hand hygiene compliance is low. They are still getting CLAPC, COWT, the bundles are in place, but the compliance is not enough, isn't it? The patients are still getting pressure ulcers, but we have the skin bundle in place, isn't it? But still the patients are getting pressure ulcers. So, although the policies are in place, but how we are making sure that we are applying those policies using the QI approach, and we are trying to become or trying to reduce the avoidable harm as much as we can do that. And that's why it is very, very important that we keep trying using the QI science or using the principles where accreditation, we use that as a, you know, putting all the policies and things in place, but trying to become better from what we were yesterday and deliver zero harm or harmless care. And that's why QI or quality improvement, it helps us in achieving that. So if accreditation is a floor, like quality improvement, it's a ceiling for me. And we really want to achieve every day what we did last yesterday, we want to be better today. So that's what I will say, that culture of continuous improvement, and that's only possible through using the quality improvement principles, and that's in a practice, in daily day-to-day practice, how we are incorporating that.
Fully agree, and I love your concept of using yesterday and today, because for me, accreditation, what I got from your answer, accreditation is something which has happened,
Yeah,
and to take it forward, we need today. And thank you
absolutely.
for an insight on it. And the second question is always, again, related to this part only, because, for India specifically, I can say, and some other countries, Bangladesh, Sri Lanka, Nepal, whenever you go to a hospital and want to, do some, advocacy for quality improvement and to convince people that it works,
Mhm.
their typical answer is, Roxa, we have our own quality department and we really do a lot of hard work and we are taking care of each and everything. So I think part of you have already answered in my next, earlier question, but still I would, love to hear from you how to, go about it, to how to, convince those people that, yeah, quality improvement is little more important along with the equity.
Absolutely. And again, very, very relatable question. When you go to any institution, oh, we have our quality department. And I remember I heard at some talk or somewhere where someone said that we should not be having any quality department in hospitals. And when I heard that, I was first, I thought, oh my God, what is this? Like, this doesn't make sense. But then what came after, it really makes sense. And why this is so? Because quality is not only quality department's job, quality is everyone's job, isn't it? So we need to
Yeah.
make sure that quality improvement principles or delivering best quality of care to our patients, it's not only quality department's job, it's everyone's job in the hospital, in the setting, from leaders to frontline to middle managers, everyone's job to deliver the best quality of care to our patients. And when people say that we have a quality department, so basically over a period of time their mindset becomes, okay, this data, oh, this data belongs to quality department, why I need to look into it? Oh, this one, this is quality. And I've seen this in multiple settings where they have nice boards in their units where the data is being displayed, and when you go and talk to the frontline staff, oh, we don't know anything about it, quality person came and they just placed this data here. And that's the thing which needs to be changed. It's your unit, it's your patients, you need to take the accountability of this one, isn't it? So it's not quality person's data, it's your data. So you need to own that. And that kind of mindset, I think we need to change, that quality is not only quality uh, department's job, it's everyone's job. And that's what advocacy or the quality advisors or the coaches, they can try to do, that building capacity and capability in the frontline staff, where maybe your primary job is delivering the patient care, but at the same time you need to have that capacity to run. Maybe you don't need the full detail of QI science, but brief about QI, like what PDSAs are, a simple run chart with just pen and paper. You don't need modern or hi-fi softwares and all, just a pen and paper, and how to look the data points, how it looks, is it looking good, it's not looking good, that's it. So this kind of capacity and capability building is really essential in frontline staff, where they have this sort of data mindset. So the things, it just doesn't remain confined to the quality department or quality people, it should be everyone's responsibility. So I think, yeah, this mindset, it really needs to change, and it will change once we will start developing more capacity in frontline staff. Slowly will, I hope we'll see that shift in the mindset.
Thank you so much. Thank you so much. Fully agree that giving ownership brings all responsibilities and the decision-making powers to the frontline workers. But unfortunately, still it's a top-down approach. Something has been thrown from the top table that you have to do this, and that rarely happens. And thank you so much again. So now I'll hand over to Muskan if we have any questions from anyone in the audiences. Over to you, Muskan.
Thank you so much, Dr. Mahtab. First of all, thank you so much, Dr. Poonam, for those valuable insights. And I think, and I believe you correctly highlighted that value improvement is no longer just about reducing cost, but it is also about delivering better patient outcomes and creating a more positive experience for both patients as well as healthcare professionals, ma'am. And thank you so much, Dr. Mehta, for that wonderful moderation and steering today's discussion with such clarity and insights. And I think with that, we'll move to the live Q&A session. And we have received some of the questions. So I'll display one of it. So one question is that how do you account for behaviors and value management in healthcare? Behaviors dominate any improvement effort as well.
Yeah, absolutely. So I always say this, like quality improvement or any quality thing, it's 20% tools, and even the tools what I have described, it is 80% soft skills. So 80% it is related to the behaviors, isn't it? So that is, you really need to keep this thing in mind. And when specifically when we were trying to work on capacity or productivity part of this work, so the behavior, this thing which came first in mind, Because in capacity part, what we do, we try to see the productivity, how much time you spend with the direct patient care, or how much time you are really spending doing the things what you should be doing in the ward. So will it be possible, like, if someone will ask me, oh, you are working 8 hours in a day, right? So how much time do you actually spend doing the work, and how much time you just, doing the chit chatting and here and there? So my answer will be, oh, I spend 9 hours rather than 8 hours. This much, I'm really busy and all. So this is not until unless you instill a sense of psychological safety, that part, it's not easy to do that. And here comes the behavior, the psychological safety part, when we try to incorporate into value management. So we try to bring all the senior leaders and the common sense of objective from the senior leadership and all, where the frontline staff, they feel empowered, the empowerment of asking questions, presenting their works. And that's the part which is hurdles. They actually do that, walk the walk, not only just talk the talk. So we are leaders, they say, oh, we really support this work and all, but actually it happens when the staff, they do huddles in front of the board. And we ask the senior leaders also to join that huddles. So when the senior leaders are there and the frontline staff, they are presenting their work in huddles, they are asking questions, they are, even if some of the they need some kind of support, or we are really short of this item, we really need this thing, and they have the opportunity to directly talk to their leaders in front, one is to one, or maybe in front of the small group, rather than going through the supervisor. And then, sometimes you feel that, oh, I can't go beyond my supervisor because that's my authority line is. But value improvement, through the hurdles, they are connecting the senior leaders to the frontline staff in real time. So when you are presenting your work, you have the opportunity to speak to your CEO if he's in the huddle, he or she is in the huddle, or if your CEO, whosoever, if they are in huddle, sir, all see last week's data, it doesn't look good. You know why? Because we do not have Cavalon cream or barrier cream. Can you please make sure that from next week onwards we have that? This small one line conversation, it saves a lot of time, it removes the barriers, and it facilitates the improvement. And so this kind of behavior changes and psychological safety, we try to incorporate into value management, which wasn't being done before. And we have seen the difference through this, and that's the way we are getting the outcomes much faster, rather than the conventional QI work where we sit into the long meetings, then proper action points and raising through the invoice. And so there is lots of steps. We are removing all the step, being lean, removing the 25% waste, and talking
Hmm.
directly to the senior leaders to remove the barriers and facilitate the work. That's how we are trying to do that.
Thank you so much, Dr. Poonam. That was an insightful response, and I think you have very well explained the topic with great clarity. Ma'am, we have another interesting question which I'll display once. That you emphasize balancing quality, patient experience, and cost. So, how can hospital leaders ensure that cost reduction initiatives do not compromise patient safety or quality of care?
Absolutely fantastic question. So it has to be balanced, quality, patient experience, and cost, because at the end of the day, patients at the heart of everything what we do. So there shouldn't be any compromise on quality. That's the very first thing. First, do no harm, right? That should be our principle. So when I say this, and when I started this, we are not talking about any sort of cost cutting. So cost reduction is always a byproduct. You try to streamline your processes, you try to reduce the waste, and you will see the cost reduction automatically. I'll give you one example. Okay, so there was this one inpatient unit where I was working on unnecessary blood extraction for the lab, isn't it? So if you will just go and look into your processes, and I looked into those processes, and I thought that we are really extracting more blood that which is required. Why do we need daily CBC for this kind of patients? Yeah, definitely there are lots of clinical things and all goes into that. And when I speak to our consultants, senior consultants, and they agreed that, oh, we don't need all this test, we just need this test, and now onwards we will try to improve our practices. So at the end of 6 months and all, we saw that there are really a good reduction in the total amount we saved from unnecessary blood test. But at the same time, We saved our patients from iatrogenic anemia. We saved our staff from needle prick injuries. So cost reduction initiatives, they should first your mindset should never be about cost reduction. Your first thing, because when I started that initiative, cost was not in my primary target. My primary target was how can we extract less blood from the patients. So if your primary focus is improving the quality, eventually you will achieve the cost reduction. You start following the CLAPSI bundle, Cowty bundle, skin bundles properly. Your patients will have less pressure ulcers, no CLAPSI, no Cowty. Automatically, you can show to your leaders that, oh, we saved a lot cost avoidance because our patients 100 days without any Cowty, 100 days or 200 days without any pressure ulcer into the unit, through or 200 days or 300 days free of falls. And you can say from my experience, it's not impossible. If you are following the evidence-based practices, it happens, and then you can translate that into, see, last year, same patient population, but we had 10 falls in this unit. This year, same patient population, but now we are more vigilant. We are using QI principles. We are using, falls tools, debrief, and all those things, and now zero falls. And now you can show the comparison of cost saving. So cost reduction, definitely it is possible without having compromising with patient safety. For me, you will improve the quality of care, but at the same time, you will see the cost reduction. That's definitely that's possible. It's always a byproduct. And as I explained for the X-ray as well, it was just a byproduct. You will see the cost savings.
Thank you so much, Dr. Poonam, for sharing these practical takeaways. And I think these are extremely valuable ahead for patient as well as for hospital and hospital leaders also. We have one more question, ma'am, that uh, yes, often value improvement term is criticized as being same as QI method. So what's your opinion on that?
Absolutely fantastic. And I never said that it's not a QI method. It is a QI method. Work is still underpinned by model for improvement. So no one should see this. It's a different QI method. We are not saying that it's not a QI method. How it is different from QI? Because in conventional QI, we never talk about finances. We never speak about finances. We never speak about productivity of our staff. So why value improvement is different? Because here we want frontline staff to take that empowerment from the finance teams. Okay, tell us how much this cost. Tell us how much this dressing thing it cost, or what is the amount of this drug. So we want frontline staff to be aware about finances in their unit. We want frontline staff to be aware of capacity, the time utilization tools, and those are the things which makes us different, and that's why it is being called as value improvement. So it is similar to quality improvement. There is no difference. Just it is one step ahead of conventional QI. Conventional QI is generally a project based approach, but in value improvement, we talk holistic approach. We include patient safety, we include quality, we include productivity, finances, and experiences. So, all these five, six things together, all the domains, and we talk about holistic care. But in conventional QI, from my experience, we are focused on one project. Okay, let's talk about length of stay. Okay, done and dusted. We really delivered, achieved our goals and objectives. This project is done. But in value improvement, we don't do that. We talk about holistic stuff. But yeah, it is same. It is same as QI. There is no second thought about it.
Thank you so much, Dr. Poonam, for clearing that up and stating the distinction also between the two of the methods that you were sharing, ma'am. So I think with that, we come to the conclusion of our session, and with that, I would like to thank you, Dr. Poonam and Dr. Mehta, for sharing those insights on value improvement, delivering better outcomes, better experiences, and better use of resources. And I think some of the key message that you shared for everyone will help them to continue to navigate through this evolving clinical landscape and challenges that they are facing. Thank you so much.
Thank you. Yeah, it was a pleasure being
Thank
here.
you.
Thank you so much. Bye bye.